Hello everyone, my name is Sushumna. I am working as a physiotherapist in Hyderabad. So today I am talking about differential diagnosis of shoulder joint. First of all, thanks to E-Physiocon for giving me this opportunity. And coming to my topic, differential diagnosis of shoulder joint. Why I chose the shoulder joint means shoulder joint is extremely flexible joint. It has wide range of motions, right? Wide range of movements. So it is more susceptible to injuries. Because of this, we have many shoulder conditions. Often we will get confused what condition it is. Like patient will come with shoulder pain. So he will say, I have shoulder pain or stiffness or something. So we should examine, we should know the history of the patient. We should know the age of the patient history and how it got, and we should palpate the patient, and we should observe the patient. Is there any muscle atrophy or muscle weakness? And we should do different special tests for the patient according to his problem, his condition. So it is very hard to diagnose each case. Means if patient comes with one problem, we may think that is a different problem, or else in some cases what happens is patient will come with shoulder problem, but if you do examination, then that is actually neck problem. For example, cervical pathology case, the patient will come and he'll say shoulder is paining, and if you do examination, then you will come to know, okay, pain is actually radiating down the elbow, arm, like that. And then you'll ask about the neck, and then you'll get to know it is a cervical disc disease. So like that, we have many what I should say, it is very hard to differentiate what condition patient is suffering from. So because we have too many conditions in the shoulder, so today I selected this topic so that we know, we'll get better idea how exactly we should treat the patient and what are the different conditions. So today I only chose few topics in the differential diagnosis of the shoulder, but we have many number of conditions in the shoulder. So I just selected like 5-6 topics or maybe 8 topics, and then I'm going to present to you all. Okay, let's start the topic and let's go to the presentation and see how what all we can do with the shoulder problems. Okay, stay tuned. So, differential diagnosis of shoulder. So, coming to history, in exploring a patient's history, ask about location, quality of pain, duration of pain, as well as associated signs and symptoms. Ask about mechanical symptoms like locking, catching, and instability. And you should also know about night pain, whether the patient is suffering during his sleep time with the pain, um, especially while rolling from one side to other side. And patient having difficulty with simply lying down may suggest impingement syndrome. This is because loss of gravity and weight of the patient arm may reproduce symptoms. If symptoms are positional, then we can consider it as AC pathology or adhesive capsulitis. So if you see patients with younger age, like less than 30 years, then they tend to have biomechanical etiology. So knowing history is very important. Knowing patient's age is very important. So biomechanical etiology, like example, a traumatic instability, tendinosis, arthropathies are common in young age children. And coming to night pain, if patient is suffering with night pain while lying down, which is on affected side, and if they have traumatic history, so then we can consider it as RCT problem or frozen shoulder problem. So these are generally old age people, like more than 65 years or 60 years. So for few people, pain with overhead activities also happens. So this indicates impingement syndrome again. And so why I'm saying is knowing history is very important. Patient's age, their occupational history, their past medical history, and current illness, everything. Next slide. Coming to physical exam. In physical exam this includes observation, palpation, range of motion, and provocative testing. Provocative testings are nothing but special tests. So uh, if you observe the patient, you will get to know whether there is muscle atrophy of that shoulder joint, whether there is any muscle atrophy or not. For example, supraspinatus muscle atrophy is there, and intraspinatus muscle atrophy can be seen, and sometimes trapezius deltoid problems also we can notice, and there is spinoglenoid cyst also can appear. So observing patient, palpating patient is very important. Check for scapular winging also. If there is any deformity, just check in physical exam. And coming to range of motion, if patient is unable to perform range of motion properly, we can consider different conditions. Like frozen shoulder people, they can't move. For them it is very hard to flex or extend or abduct or anything, any motion, it is very hard, it creates lots of pain because their muscle is all stiff. So loss of active motion alone suggests RC tear or nerve injury. A loss of both active and passive motion suggests a mechanical block, such as labrum tear, adhesive capsulitis, or severe impingement. Access the power, stability, and range of movement. So that is what you have when you are checking the range of motion. You will get to know many things. You will have an idea about different condition patient is suffering, patient is going through. So passive loss of motion is seen in frozen shoulder and degenerative joint disease. Active loss of motion is seen in RCT, and muscle weakness is also seen in RCT. Next, palpating shoulder. So palpating front and back and all these important joints like AC joint, SC joint, you have to palpate clavicle, acromion, greater tuberosity, coracoid process, pectoralis major muscle. Um, Especially you should check for tender areas. Look for tender areas and check for whether there is any swelling, warmth, redness, and check for crepitus also. Palpable tenderness or swelling suggests injury to the underlying structures. Next, provocative tests. There are many provocative tests for many of the shoulder conditions. Each shoulder condition we have like at least nearly 8 to 10 tests to perform, but in general we'll see 3 to 4 tests minimum for every shoulder condition. So I can't explain each and every condition here, every special test in this shoulder conditions. I written few of the important names: drop arm test, lateral rotation test, infraspinatus test, teres minor test, lift off sign, tinal sign, knee impingement test, Hawkins Kennedy test, Roos test, right test, costo-clavicular test, Speed's test, Edgerson's test, empty can test, clunk test, bicipital tension test, biceps load test, slap prehension test, load shift test, apprehension test. Like this, we have many tests. So like I said, for every condition we have to test at least minimum 4 or 5 special tests. Like for example, for rotatory cuff or for impingement, we'll go with knee impingement test, Hawkins Kennedy test, empty can test, drop arm test, lift off test, infraspinatus test, spring back test, teres minor test, teres major test, and apply scratch test. If you have a AC joint problem. Then first we'll check painful arc, and second forced adduction test. Forced adduction test in hanging arm, and Duga's test is one of the familiar tests. And next, if for biceps, everybody does the Speed's test, Edgarson's test, etc. So for instability, again anterior apprehension test, posterior apprehension test, anterior posterior drawer test, and inferior instability test, sulcus test. Coming to one more important thing, shoulder versus cervical spine. Many times patient comes with a shoulder problem, but it is actually neck problem. Why this happens? Because the neck and the shoulder are intimately connected by multiple nerve pathways. When injury occurs, the brain can't always trace pain pathways back to their source. And what we feel may not be what is really going on in the backside. So this is called referred pain. So patient feels pain in the shoulder, so he'll come and he'll say, but if you ask, if you test properly, then you will get to know actually pain is radiating down the elbow, mm, behind back, around scapular area, around shoulder area, around neck area, and we'll ask about what is the type of pain. Is it stabbing, burning, tingling sensation will be there, electric like stimulation, electric like sensation will be there. Pain will radiate down the elbow, sometimes even to the hand. So taking diagnosis of the patient is very important. Next comes rotator cuff injury or tear. Here, rotator cuff tears are most commonly seen in 60 years. That means older people or around 60, 65, like that you can notice rotator cuff injuries. And we can also see rotator cuff tears in people who does repeated activities and who are carpenters, who does painting job. So knowing a patient's occupational history is very important. When you are taking history, take occupational history, and check whether they are doing any construction jobs, because they may have this rotator cuff pathology. And you check for what kind of pain they have. In rotator cuff injury, we have dull ache in the shoulder. So here patients tends to be awakened from sleep or having difficulty falling asleep because of the shoulder pain. Means when they are sleeping, in between the sleep they'll get up because of the extreme cruciating pain in the shoulder, and they can't sleep back. This occurs because of this rotator cuff tear. Decreased strength in elevation, abduction and drop arm is noticed. Supraspinatus or infraspinatus weakness with abduction and external rotation is seen. Subscapular weakness in internal rotation is seen. Belly press, shrug sign, night pain, drop arm test and external rotation lag sign will be positive. Crepitus also is noticed. Next comes shoulder impingement syndrome. In shoulder impingement syndrome, see, if you notice this slide, you can see there is reduced subacromial space here. Here, normal slide, there is a normal bursa. There is no impingement noticed here. So, this happens between 35 to 55 years of age group, and here we'll do impingement tests. This impingement syndrome is mainly noticed in people who will swim, who are into tennis. I mean athletes who does all overhead activity repeatedly. They'll have this problem, like painters also, people who will lift loads in the overhead. So for them also you can notice impingement syndrome. And this impingement syndrome can lead to inflammation of rotator cuff tendons and bursitis also. So how do you know you have impingement syndrome? So pain or clicking when putting your hand behind your back, pain reaching for the seat belt, and arc of the shoulder pain approximately when your arm is at the right shoulder height or overhead. pain when lying on the shoulder, shoulder pain at rest as your condition deteriorates, muscle weakness or pain when attempting to reach lift. So you can't do any overhead activities here. You can't even take your hand back, especially during showers. You can't even rub, you can't even brush your back. It will be very hard, and you can't reach seat belt and anything overhead. If you want to take anything from overhead cabinet, you can't reach there because of this extreme pain. And pain is there in the night also, means while lying down on affected side of the shoulder, pain will increase. So we should never lie down on affected side of any part of the body. Next slide. Frozen shoulder. Frozen shoulder is otherwise called as adhesive capsulitis. If you see, inflammation is there in the capsule, and in this slide, if you notice this slide, there is thickening of joint capsule and adhesions formed here, and we can see the difference between normal uh, uh, shoulder as well as frozen shoulder. There is lot of inflammation here, and joint thickening is there. So here this occurs mainly around 40 to 60 years, and especially for women, and that too for diabetes and autoimmune disorders like hypothyroid. And there will be limited range of motion. Patient can't perform any kind of test because it is all stiff. Shoulder is stiff. So patient cannot reach heights, cannot lift. Um, he can't even do regular normal movements like flexion, abduction, extension and all. And next comes biceps tendinopathy. Biceps tendinopathy, pain is there in anterior shoulder and Popeye deformity is noticed. May have pain in the supination as well, and tenderness on palpation of bicipital groove. So palpation is very important in all muscles, especially if you palpate for any biceps tendinitis or tendinopathy or any disease, you have to palpate on the bicipital groove as well. And if you go for special test, speed test is positive, O'Brien's test is positive, and Ergerson's test is positive. Next is slap tear, a superior labrum anterior posterior tear, more commonly referred as slap tear. It's a specific type of glenoid labrum tear, that is nothing but shoulder joint tear. The most common cause is falling on outstretched hand. So this is commonly seen for athletes, that too who will have this overhead activities like baseball pitchers, and the people who will work repeatedly in overhead activities like uh, all this constructing workers also. You can notice the slap tears. We can see deep shoulder pain here. There's a catching sensation, popping sounds or crepitus sounds may be noticed. There is loss of glenohumeral internal rotation range of motion, inability to lie on affected side of the shoulder. So what are the special tests you will do is O'Brien's test and Mayoshi test are positive. Next comes AC joint sprain. This happened because of the accidents or traumatic injuries to that AC joint. So if you notice this slide, you can see a bump on his AC joint. So disfigurement of shoulder happens, and there will be bump, there will be bruise, there will be pain, lot of pain. Patient can't move his hand upwards. This occurs because of falling on outstretched hand or falling directly on the elbow. So bulge is noticed, shoulder droop is noticed, collarbone that moves upward, limited movement in the shoulder. So just by observing, you can tell that is AC sprain. Next comes calcific tendonitis. Here, what happens is calcium gets deposited in rotator cuff tendon. That is calcific tendinitis. Because of this, inflammation happens. That inflammation is called calcific tendinitis. Mostly women will get like 70% of cases, that to engage at least in the middle age, 30 to 40 years age group, and it is self-limiting condition. Means it will no need of taking special treatment, because it will reabsorb in the body as years go. Next, further diagnosis. So coming to further diagnosis, um, if you want any further confirmation, you can send patient to X-ray, MRI, CT scan based on their conditions. But just with history, physical exam, palpation, observation, and some special test, you will understand 80% of the patient's case. So um, here we understood that if patient has a radiating pain, we'll think about cervical disc disease. If supraspinatus or infraspinatus wasting is there, we'll think about RCT or suprascapular nerve entrapment. If there is clunking sounds or popping sounds, then we'll think about labral tear. If there is night pain, then we'll assume it may be impingement. Okay, if there is a ligament laxity issue is there, then we think this may be instability case. If patient can't reach behind his back, or can't brush his hair, or he can't do overhead activities, we'll think it is RC problem. If by seeing patient's age, we'll think if he is older and his shoulder becomes stiff, then we'll think maybe this is frozen shoulder. So like this, just by observing the patient and doing some this minimum special test or physical examination, palpation, will understand 80% of the problem, what patient has going through. So without even seeing X-ray or MRI. So many physios predict patient's problem before seeing X-rays. So this amazes the patient and their families. They wonder, without even seeing our scan reports, this physio predicted correctly. So this happens with deep, thorough knowledge in all conditions. So there are many shoulder conditions. I didn't explain them all here. So keep learning. And is there any slide? Okay, that's all. Um, After diagnosis, we can plan for our further treatment protocol. So this is the end of my presentation. So please go through, and if you have any questions, ping me at sushumna2020@gmail.com. Thank you all once again for listening to me, and thank you E-Physiocon for giving me this opportunity. Thank you very much.